So the past few slides are just for review of respiratory system anatomy if you need it. But what this image is of a transverse section of our thoracic cavity. And so you can see our lungs really well. You can see the trachea right here. This is the anterior side. This is the posterior side. You can see, your blood vessels pretty well in the heart chambers. But what I want you to look at is notice that there is a gap in the thoracic cavity between the rib cage and the lungs. So again, this is review from anatomy 2, but we have our layers here of membrane that surround our lungs like a water balloon. Deep to the thoracic cavity, so on the surface of the lung, is the visceral pleura. It's in light blue. It's on the surface of the lung. And then along the wall of the thoracic cavity, the thoracic wall, we have the parietal pleura, and that's shown in like this lime green color. And in between those two membranes is the pleural cavity, and you can see it's just like a really thin gap. And within this pleural cavity, there's going to be a thin layer of pleural fluid. And this is to reduce friction in the area, because our lungs are moving within the thoracic cavity. But this is going to play a role in breathing mechanics. So this cavity that's filled with pleural fluid is called the interpleural space. And a lot of times the parietal and visceral pleura can be kind of stuck together, so they move together. So we will be talking about the mechanics of respiration. And to do that, let's just talk about a few things first off, because there's a lot of words, there's a lot of terms that use the word respiration in it, but they mean different things. First off, when we talk about pulmonary ventilation, that would just be the air moving into and out of the lungs. The word pulmonary has to do with lungs. So that is the actual air coming into and out of the lungs. When we talk about gas exchange, that is can be defined in two different places. We recently spoke about it between blood and tissue cells because we were talking about capillaries. And so we've talked about how gas exchange can occur between blood and the simple squamous epithelium of capillaries. But another place that gas exchange occurs is between the air and the blood in the lungs, because it's here where we are oxygenating blood in the first place. So that is gas exchange. And then we have these different terms down here. Cellular respiration, also known as aerobic respiration, something else we also talked about recently. It's not necessarily what we think of when we think of respiration, but this is how we make ATP by use of mitochondria and oxygen. It's called respiration because it does use oxygen. And then we have two final types of respiration: external respiration and internal respiration. External respiration is going to have to do with the ventilation plus the gas exchange between the air and the blood in the lungs. So it kind of takes in pulmonary ventilation as well as the gas exchange between air and blood in lungs. Internal respiration has to do with the gas exchange between blood and tissue cells, like when blood is moving through capillaries to oxygenate tissue, and then the use of that oxygen for cellular respiration. So we just mentioned the pleural space, the intrapleural space with the visceral pleural and the parietal pleura. There is pressure in those spaces. First off, there is pressure in the lungs, and this is going to be important in breathing mechanics. There's pressure in our lungs. And oftentimes it's negative pressure, but pressure in the lungs is called intrapulmonary pressure. And then pressure in the intrapleural space is called intrapleural pressure. And this is going to impact breathing mechanics. So, ventilation, air coming in or out of the lungs, is going to happen when there are differences in pressure that are induced or began by the changes in the lung volume. And air is always going to move from higher to lower pressure. And there are going to be some characteristics here that are going to influence ventilation, which we'll talk about. The pressure of gas within our lungs is inversely proportional to the volume of gas within our lungs. And so I have this GIF here. It's not working, but as you can see, there's somebody pressing down on this toy, and when they push down on it, all of this stuff comes out, and then this thing is kind of like smushed, you know. And what this is trying to show that there is a negative pressure in this little guy after this has been pressed down on. Another example of this would be like when you squeeze out too much sunscreen and you're trying to suck it back in to your sunscreen bottle. You kind of press on it so that it creates a vacuum. And when you're doing that, you are exerting a negative pressure so that it sucks it back in, you know? And this has to do with Boyle's law. So Boyle's law says that the pressure of gas is inversely proportional to the volume. And what that means is when the volume of air in the lungs is high, the pressure in the lungs is low. When the pressure is high, volume is low. And let me show you a image of this or a GIF of this. So this is actually from your textbook, and I just want you to see the intake here. So what I want you to see here is notice that I'm actually dragging these. And so I'm dragging this slider to increase the volume of the lungs. And when I increase the volume of the lungs, it creates a negative pressure. Kind of like that, example of sunblock or that little GIF that I have of the smiley face vomit thing. So when the volume is high, there's a lot of air volume inside our lungs. There's really low pressure, and that's what actually causes us to inspire, to intake and inhale. When pressure is high when volume is low, like with an exhale, pressure is high, and that's what's actually pushing on the lungs to push air out of our trachea, out of our respiratory system. And so this is in your physiology textbook. I'm using MH education. So check out your electronic resources. There's kind of cool animations that you can play with. A couple properties that are going to impact ventilation. First off, we have compliance, or how easily a lung expands. And depending on, disease, a healthy lung should have relatively high compliance. But if you have disease, that can reduce compliance by causing resistance to allow our lungs to expand as they should. An example of this would be pulmonary fibrosis, where you get fibrous tissue on the tops of our lungs. Another property would be elasticity. Elasticity, like an elastic band, like a rubber band, it's not only the capability to stretch, but then the capability to return to its original shape after stretch. And so this allows for resistance of stretch. And to do this, we have to have a lot of elastin fibers, which are found in our connective tissue. And then lastly, we have surface tension. Surface tension has to do with water and the ability of water molecules to bond together with hydrogen bonds. Imagine how painful it is if you were to belly flop in a pool. That's because of the surface tension of water. The surface tension of water is going to impact the alveoli shape, and it's directed inward. And so what that means is that it's going to raise the pressure inside the alveoli. And we just said if there's high pressure, there's going to be low volume because of Boyle's law. And so what that does is it does not allow for as much air volume in. And in fact, it also can promote alveolar collapse. So the lungs will not be able to expand as much as they should. This is actually somewhat relevant to COVID-19. If you can remember back in 2020, when the first symptoms of COVID were coming out, shortness of breath, it was because of accumulation of fluid in the lungs. Accumulation of fluid in the lungs, surface tension is like the very minimal side of that, and COVID is probably like the maximal side of that. But what that does is it allows for less volume of air. So lungs do secrete fluid and they do absorb fluid. And normally there's a thin film of fluid on the alveolar surface, which is why surface tension can cause an issue. This fluid absorption occurs by osmosis, which is driven by sodium active transport. Fluid secretion is driven by active transport of chloride out of alveolar epithelial cells. And film causes surface tension because the water molecules want to bind to other water molecules via hydrogen bonding. Just like belly flopping in a pool. So something that our lungs have to combat this surface tension is a molecule called surfactant. Surfactant is like this soapy kind of consistency, maybe kind of oily consistency that specific cells in the alveoli produce. And these cells are called type 2 alveolar cells. Type 2 alveolar cells are going to produce this surfactant. Again, it's kind of oily. It's made out of phospholipids. And the way it works is that it gets in between these water molecules to reduce their ability to hydrogen bond to each other. And with that reduction of surface tension, it is going to allow for alveoli to stay open. It allows for alveoli to stay open and to not collapse. As you can see in these pictures down here, if this were number 1 and this were number 2, in this picture on the left, which alveoli would collapse if there was a pressure exerted and volume decreased? Number 1 would collapse because it's smaller than alveoli number 2. But with surfactant, that is prevented because of this kind of breaking up of water molecules and hydrogen bonding. So surfactant starts getting produced around week 24 of fetal development, and it continues on till about week 36, maybe 37. And so for babies who are born premature to week 36 or 37, they're often born with an immature surfactant system, and so they have risk of their alveoli collapsing completely. And our alveoli never completely collapse. They should always have some negative pressure exerted, and so some volume of air inside them. And so, these babies who are born this young stay in a respirator so that they have that assistance with breathing until they've produced enough surfactant for their lungs. So a couple pulmonary disorders, and just FYI, I passed through those spirometry slides because I know you're going to talk about it in lab, because you're going to use those in lab. So we're just going to focus on other things here. Asthma. Asthma is caused by uncontrolled or unregulated constriction of bronchioles, and this can be caused by inflammation, by excess mucus secretion, and so it causes wheezing. And then allergic asthma is triggered by allergens, which are going to stimulate your immune system response, your white blood cells, which we will talk about soon, to release factors that are going to initiate the inflammation response. Emphysema is irreversible, and it is just the destruction of simple squamous epithelium, the epithelium of the alveoli. So if you take away the alveoli, you are reducing the surface area at which gas exchange occurs. If there's fewer alveoli, there's just going to be less gas exchange occurring. Smoking is the most common cause of emphysema. And again, as I said, this is irreversible. And so if you could see this beneath, if you could see a gross lung of this, and maybe you can Google an image, a picture of this, your lung just ends up looking kind of like a plastic bag rather than having like a spongy texture to it. COPD is also irreversible, and it has to do with chronic inflammation and narrowing of the airways and alveolar destruction. So this includes emphysema. Emphysema and COPD can be diagnosed together, as well as other disorders like chronic obstructive bronchitis. This can cause inflammation, or this inflammation can be similar to what we just spoke about, how you have your immune system response that are going to initiate the response of inflammation, excessive mucus production. And so COPD, it's usually because people smoke. And so your lungs and your respiratory system are trying to remove that with this mucus production and inflammation response. So gases, atmospheric pressure is about 760 millimeters mercury, as you can see in this picture, and that is the pressure of the atmosphere. The atmosphere is made up of a few different gases, mostly nitrogen, more nitrogen than oxygen, and then small amounts of carbon dioxide, and even small amounts of water, which is, humidity. The partial pressure is the pressure of any particular gas. So for an example of this would be the pressure of nitrogen gas, because it makes up 78%. Its particular gas pressure would be 593 millimeters mercury. But the sum of them all together is 760 millimeters mercury. As you go higher in altitude, the atmospheric pressure decreases, which is why it's harder to, oxygenate tissue at higher altitude, because there's less pressure of oxygen in the air. So gas exchange in lungs is driven by differences in partial pressure of gases between the alveoli and capillaries. And it is going to go from higher pressure of a gas to lower pressure of a gas, just like passive diffusion. This is facilitated by the surface area of alveoli. It happens along the surface area of alveoli. So if I were to draw alveoli with my simple squamous epithelium, or say this is a capillary and then an alveoli here, that's how gas exchange occurs. It occurs all along the membrane. And so, like in the example of emphysema, if you take away the membrane by taking away the simple squamous epithelium, there's just going to be less gas exchange occurring. So not only do we have a large surface area of lung tissue because of these grape-like structures of the alveoli, notice how many capillary networks we have surrounding each alveoli. There is a huge density of capillaries here which assist in this gas exchange. So again, it's going to go from high to low, and it's just based off of passive diffusion. Movement of oxygen and carbon dioxide are going to go from higher to lower concentration, and so the same thing is true of pressure. Carbon dioxide and oxygen are going to move from higher pressure to lower pressure simply via passive diffusion. In the lungs, shown here, the pressure of oxygen is really high. The pressure of oxygen or carbon dioxide is lower. So the pressure of oxygen is going to go from high in the alveoli to low in the capillaries. The pressure of carbon dioxide is going to go from high in the capillaries to low in the alveoli. In the tissues, carbon dioxide is high, and it is going to go from high in the body cells, in the tissues, to low in the capillaries. And then oxygen is going to go from high in the capillaries to low in the body tissues. To regulation of breathing. So in this table over here, we have first off, two major portions. We have voluntary breathing, and voluntary breathing is directly controlled by the cerebral cortex. And then we have automatic breathing. And as you can, automatic breathing, which is controlled by the medulla oblongata. Within the medulla oblongata, there are two respiratory groups. The dorsal respiratory group, and that is where inspiratory neurons drive inspiration. So this is going to excite and cause inspiration. And then we have the ventral respiratory group, where expiratory neurons inhibit inspiratory neurons. And this is going to allow for expiration. Notice in this table, the medulla is also getting information from the pons, and so it's getting information from the pons as well as information from some blood vessels. So what controls our automatic breathing, our medulla oblongata is influenced by chemoreceptors. And these chemoreceptors are going to measure that partial pressure of carbon dioxide, that partial pressure of oxygen of the blood. And similarly, we'll also monitor the pH. And we're going to show you how actually one can influence the other. So there are chemoreceptors that influence the medulla oblongata, and there are also chemoreceptors within the medulla oblongata. And these are also sensitive to changes of the cerebral spinal fluid. The cerebral spinal fluid is blood plasma adjacent. And so, this is going to be able to monitor the pH, for example, of the cerebral spinal fluid. And then it is going to take in information by these other chemoreceptors, which we call peripheral because they're kind of on the sidelines. And these are in the aorta and in these nodules called carotid bodies, which really are right next to our common carotid arteries. And these are going to pick up the hydrogen concentration within our blood. And so our medulla oblongata is getting a bunch of chemical information telling it about the carbon concentration, carbon pressure, oxygen pressure, and the pH of the blood, the cerebral spinal fluid, as well as hydrogen concentration. As I mentioned before, the pressure of carbon dioxide has an impact on blood pH, because what we're going to learn is that carbon dioxide can dissociate with water, and it kind of acts as a weak buffer is what we call it. It can make bicarbonate, which is shown right here, or it can make a carbonic acid, which is a weak acid, but it is an acid nonetheless, and it would decrease pH. And so high concentrations of carbon dioxide are kind of the most crucial to measure because of its effect on pH. The pressure of oxygen actually has very little effect in regulation of breathing because at any given time, the pressure of oxygen is relatively high. The pressure of oxygen would have to fall to about half normal before ventilation is actually significantly affected. And so, I'm actually reading this book right now called Breath. It's been taking me forever. But this author also writes about free divers. And what a free diver is somebody who trains their body to be able to hold their breath for long periods of time so that they can dive deep in the ocean. We're talking like 50, 100 meters plus. And they do that by kind of hijacking this science of understanding that what drives them to take a breath is the carbon dioxide levels here. Carbon dioxide is what is sensed in the adrenal medulla, and this is going to decrease pH because of that production of carbonic acid, and this will increase ventilation. This chemoreceptor sensation is sensing carbon dioxide, not hydrogen ions. It's sensing carbon dioxide. And that's because hydrogen ions do not cross the blood-brain barrier. And so this takes a little longer. This is not like a really fast fix if there is increased carbon dioxide within the fluids of the brain. But it takes longer, but it is responsible for most of our increased ventilation, about 70 to 80%. So aortic and carotid bodies, which again were on our aorta and around our common carotid arteries, these are actually going to respond to hydrogen ions because of those increased carbon dioxide levels. So these actually respond much faster than the chemoreceptors within the adrenal medulla and cause a change in ventilation a lot quicker than the other mechanism. So this is kind of a confusing graph here, but let's start at the top where we have maybe for some reason, decreased amount of ventilation. So for some reason we have increased pressure of CO2. Increased CO2 is going to possibly produce that acid, that weak acid, and that is going to decrease pH of blood. And that will be most swiftly, it will be sensed via those peripheral chemoreceptors within the aorta and carotid, via those aortic bodies and carotid bodies. And then that is going to impact the respiratory center within the medulla oblongata and change the respiratory muscles via the spinal cord, via our motor neurons, and it'll increase ventilation. That would happen quickest and fastest. But what would also happen is this increased pressure of carbon dioxide is going to increase the carbon dioxide in the blood, which is still going to decrease pH, and it's going to decrease the pH of the interstitial fluid. Reminder here that the chemoreceptors within the medulla oblongata do not measure for hydrogen ions, but it is able to sense pH. So this reduction of pH is going to activate the respiratory center, which in the medulla oblongata, which is going to activate our spinal cord and motor neurons, which then allows for activation of the respiratory muscles, increasing ventilation.